All right, welcome back, everyone. Welcome to the last episode of our pharmacotherapy series of the ICU course. I'm pharmacist Hanli. So today's learning objective is around common use of vasoactive and resuscitation agents in the critical care or daily practice. So we're going to look at the several common vasoactive agents and with their clinical implications. Firstly, focusing on different types of shock etiology, and then we're going to jump to the ALS sections and with a focus around the 2025 updates in between the AHA and also the ERC, European Resuscitations Care Association, to the latest pharmacotherapy updates with these vasoactive agents. And then I'm trying to seeking evidence-based drug selections and also some titration tips when it turns to a different shock status, and especially for the Vasopressin use. All right, so first of all, as a quick review of our hemodynamic monitoring, we all know that the shock representations is defined as the hypertension's presence as the mean arterial pressures below the 65, but not just only hypertension, but also with a tissue poor perfusion, which is defined as the hyperlactatemia, and or reduce the venous oxygen saturations. So here we're going to look at the saturated of the venous oxygens, which is defined as less than 70% compared to a normal physiology. And in terms of the saturations oxygenation level in the central venous, normally it is actually below the peripheral venous oxygen by 2 to 3%. However, in the shock status, the central venous oxygen has actually accumulated higher compared to higher than the venous peripheral oxygenation amount by 5 to 8%. And when it speaks of differentiate different types of shock representation, it is quite important to not just define by the static level, such as the central venous pressures or just the the blood pressure itself. We need to look at into the details, such as the compositions of blood pressures is not only the cardiac output per minute or per stroke, but also with the peripheral help from the systemic venous resistance, or also called as the SVR. And what does compose of the each cardiac output? It is the stroke volume times the heart rate itself. So it is quite important to know about the stroke volumes here. You can imagine it as a preload, and also each stroke itself is in terms of the contractility of the heart rate, and also there is the systemic venous resistance. It's just like the afterload of the blood. And here we look at the next slide of the hemodynamic monitoring device. It is quite important that the foundations of these discussions, although it's just around the shock management, but if you cannot dedicate it in differentiate the shock type at the front, then it may be less efficient in addressing patients' issues, and even to select the best choice or the best optimization for your vasoactive agent strategy. So here we define the shock by the two main criteria, and understanding of this category is quite important. So with all these facts, such as the cardiac output or cardiac index, the SVR and the SV and also the SVRI is these parameters is now can be measured by we call it as the hemodynamic monitoring device, And the end of these device selections is quite pursuing as less invasive as possible. So on the screen, you can here look at several devices such as PICO or PRACTP, and some is also called as minimal invasive devices that they actually measuring the patient's arterial pulse pressure by each waveform and also count into analysis. But just keep in mind that if a patient comes into any consequence of arrhythmias, then the arrhythmia status can actually reduce the accuracy of these reported data because each arrhythmic stroke or arrhythmic resonance is all influence the accuracy in measuring these parameter. So and if you choose the PICO, to remember you need to insert the CVP value and also to use the A line to better calibration. Just here's for example as the several monitoring device that we actually use in the Wanfang Hospital on ICU ward. And the next slide is we're going to look at the main category of the shock, and I'll try to recode to each hemodynamic. So again, if you cannot really exactly measure the SVR or the CO, then it will be just less efficient for the providers to figure out what happened with the patient by merely the patient's the history taking. Like can be quite time consuming at the front, and actually time is life, especially for the acute phase for the patient undergoing the shock status. All right, so first of all, let's go to the first category as hypovolemic. So hypovolemic shock involves a drop in the preload and also decrease in the cardiac output. These are the two main interpretations and the features. And the cause of hypovolemic could be anything from the fluid decrease in any like the blood loss or severe diarrhea from the gastrointestinal systems or running out from the third spacings like the burn patient is called can go lead to the hypovolemic presentation. And also to note that there might be a reflex of increasing SVR from the compensations of body systems because your body is trying to maintain the tissue perfusion as best as they can. And the second category is distributed shock, or so-called as a vasodilatory, and such as the sepsis or any like anaphylactic situations can run over in two, and is dominated by the decrease of the systemic venous resistance. Because during the vasodilatory, such as the vessel itself is actually in a dilation phase, so either caused by the histamine mechanisms or just the surge as the part of the inflammation process due to the sepsis influence. Sorry. Therefore, in the distributed shock status, the vasodilatations and the vascular permeability are increased and attributing by cytokines and inflammatory mediators. So it's quite important to increase the systemic venous resistance as part of the management strategy. And also the main focus is try to fix the cause of the problems, which is to decrease or to manage the inflammation process. And the third category of the shock is cardiogenic, or so called as a CS. So cardiogenic shock is primarily leading by the heart failure and resulting primarily in the increased blood preload and with a very low contractility, so the low CO, And if the afterload increase, then you might see the SVR will increase as well in this situation. So remember, a patient with running with a heart failure may be presenting by either the right heart failure or the left heart failure. So it's quite important to determine whether the preload is increasing or the SVR increased. So in that situation, you could quickly understanding if we need to try to avoid choosing any agents further to increase the SVR, or we can primarily choose the inotropes that can decrease the preload as a first thinking process. And last is the obstructive shock, and such as causing by any stuck in the systemic circuits, such as the pulmonary embolism, any tensions, pneumothorax, or the pericardial and tamponade can all lead into these situations. And the impairment in diastolic filling or the systolic contractions is all in that type. So as you can imagine, the preload is going to decrease or increase here, sorry for the typo, and the SVR is going to increase with a low CO. And we all know that when we need to determine different vasoactive agents on this specific receptors, there are primarily a lot of them to participate in these circuits. So the receptors alpha-1 that's located in peripheral, renal, and coronary circulation, it causes vasoconstrictions as a reaction. As the beta-1 receptors is located in the heart, that increase the contractility and also increase the heart rate as a consequence. As for the beta-2 receptors, it's primarily focusing not only in the peripheral, but also the coronary circulations and in the lungs itself. That's why it can cause the vasodilations or the bronchodilation effect. As the dopaminergic is around the mesenterics or the renal areas and has led to a mild vasodilation effect as well. And as for the V1 and the V2, as the part of the arginine vasopressins, it actually the V1 is focused in the visceral organs, and that cause the concentrations to that area can sometimes cause the damage to these organs, or leading to the adverse events such as mesenteric ischemic bowel. As for the V2 receptors located on the kidneys, is primarily its role is to increase water reabsorptions in the kidney. And as for the common inotropes and vasopressin agents are listed here. This table summarizes the activity and the clinical effects of our main agents. So first of all, in a series of the pressors, that the first phenylephrine is a pretty pure alpha-1 agonist, which provides a strong SVR increase with no change in the 2CO. And then as the norepinephrine and also epinephrine, they're all part of the belongs to the category of the catecholamine. So norepinephrine is a potent alpha-1 and beta-1 agent, which highly effectively increase the SVR. And the epinephrine provides a balanced effect. As a lower dose, the CO would increase because of the beta-1 effect, but in a higher dose, that is the alpha-1 dominant, and will increase the SVR as these effect as well. And then the dopamine is highly dose dependent, and shifting from primarily as a dopaminergic when it comes to a very low dose, and then would increase to beta-1 effect, focusing on the inotropic and increase the CO. And when it goes to a larger dose range, above the 10 microgram per kilogram per minute, then it's the alpha 1 effect that dominates the dopamine driven, and also with partial the beta 1. And lastly, the vasopressin of the vasopressin is a pure V1 and V2 agonist, which cause the a pretty pure SVR increased without impact the CO as well. And then sections of the inotrope we already see is actually with the beta 1 effect. The CO could be influenced, but just with the pure or not. So dopamine is sometimes at least above the 5 microgram per kilogram per minute, and has dominant with the beta 1 effect. But other than dopamine, is Dobutamine is actually has the highest, as a quite pretty powerful beta 1 agent, which maximizing the CO while kicking at lowering the SVR, unlike the dopamine. And then we have the isoproterenol that has a beta 1 and both beta 2 and effect, and also the Milrinone is a PDE3 inhibitor that is actually can not only increase the contractility to the heart, the coronary vessel, but also it decreased the afterload, and also decrease the pulmonary venous resistance, the PVR as well. So it can help not only in the right heart failure, but also especially for the right heart failure, can be helpful with the Milrinone's choose as well. And last is the levosimendan. So levosimendan, we're not going to talk with more details in this section, but it emphasizes with the mechanisms to sensitize the calcium channel, and with the ATP activation. So it largely increased the contractility of the heart, and you can see the CO increased pretty soon after levosimendan's use. But it also causes vasodilation effect sometimes, so it generally has the hypertension side effect. And we're going to focus on the two main categories of the shock, and get the vasoactive agents management theory. So septic shock is the first one, and we know, as listed here, is charted by the Surviving Sepsis Campaign, the SSC, which guides our septic shock management. And in terms of the pressure, in the septic shock, the norepinephrine is always the first line, targeting the MAP to over 65. Do we remember with other choice and considers as long as the second choice after the norepinephrine is the vasopressin, and the timing of vasopressin initiation is usually started when norepinephrine is around the dosage of 0.25 to 0.5 microgram per kilogram per minute. And then if there is inadequate the increase of the MAP, despite the first and the second line of pressures, then consider to adding epinephrine. And if the patient presents not only with a septic shock, but also other cardiac dysfunctions that can you cannot rule out, if there is also mixed with cardiogenic shock, then you may consider to adding the dobutamine as the inotrope, or more switching to the epinephrine when needed. And in terms of the for cardiogenic shock, same as the septic shock, the norepinephrine is the first line here as the pressor. And then in terms of the inotropes choose, dobutamine because is the selections of recommended, because it especially for those with a low cardiac index without severe hypertension, hypertensive because dobutamine can truly improve the myocardial contractility. And then consider dobutamine and Milrinone for both low cardiac output, and especially Milrinone, as we mentioned, that may be preferred in those reasons have a beta blockade or in concomitant pulmonary hypertension due to its quite potent vasodilatory properties to the lung. And as the PK difference of the pharmacokinetic, the dobutamine has a faster onset time and shorter half-life compared with the Milrinone. And for safety issues, there is actually no difference in clinical efficacy or safety. So, but just remember, both should be closely monitored for any occurrence of arrhythmia signs and worsening ischemia. And then we have each one as the specific introductions that we will go through together. So put attention to not just only of these vasoactive agents in the shock time, but also if the medication here is also commonly have other indications for the emergency setting as well. And just remember that those may be different, so be sure to look into the right indications when you try to dosing in different situations of a patient. So first is the norepinephrine, and this is the how it looks like for the products in our hospital. So indicated as most of the first-line pressors for both cardiogenic, septic, and distributed shock. It has a different continuous infusion dose as a starting. And for the precaution part is you might need to dilute it to the concentration that is proper in whether it's dosing in a central venous line or is in the peripheral. And also remember that to administer with the CBC available is highly recommended. Because if you administer the norepinephrine with higher concentrations in the peripheral line, it may cause just tissue necrosis by extravasation. And in the reconstitutions of norepinephrine, do not mix with any alkaline solutions, and proper with the glucose as a dilutions as well, just to increase its stability. And the side effect of the norepinephrine, including such below and particulars in the respiratory difficulty and the palpitations, just the tachycardia. The second agent as the Vasopressin. It is the second line for the septic shock and known for purely increase of the SVR, the systematic vascular resistance. And as the dosage, do remember with the initial at the 0.01 unit per minute, it can be as a with a scale of 0.01 from the scale 1 to the level 3 is the 0.03 unit per minute. And it should be noted if the patient is concomitant, both use the norepinephrine and the vasopressin at the same time, and when the shock is getting better control, and we would try to taper the vasopressor. And in terms of these two medications, it is highly recommended to always taper vasopressin last. So taper vasopressin only after the catecholamine-related vasopressors, such as like norepinephrine, had been discontinued, and I will explain why and with the evidence later. And the main adverse effect is the vasopressin. With vasopressin, should be cautious primarily with the peripheral limb ischemia, or the visceral mesenteric valve ischemia event, and also with accumulated causing the atrial fibrillations or bradycardia related has all been reported. So this is the quite a few randomized controlled trial have been exploring the sequence of whether to taper norepinephrine or vasopressin first after the first recovery phase from septic shock. And here you can see from the meta-analysis with up to 1,000 patients that it is quite obvious if to favor to discontinue norepinephrine first, which is to start choosing norepinephrine as the first agent to start tapering the dose. Otherwise, what if we do in the other sequence to taper the vasopressin first? Then the studies of consistently presenting of the increased risk of the rebounding hypertension as the sequence. So part of the reason is because of the pharmacokinetic features that the vasopressin actually has a higher half-life. So do remember as a take-home point, if your patient is both running norepinephrine and also the vasopressin and is getting more stabilized, then discontinue norepinephrine first, then starting the vasopressin as the second to taper down the dose. It is quite important. And then let's look at the epinephrine, which it has actually a lot of the common emergency indications, such as anaphylactic shock, also during the cardiac arrest phases, to help with the each of these rhythms from asystole, PEA, ventricular fibrillations, or pulseless VD. And it also helps with the when the hemodynamic unstable bradycardia or the AV block after trial of atropine. And the common dosing as listed. Do we remember with the precaution things that epinephrines could not be mixed with other alkaline solutions, just like a furosemide, and it needs to be injected into a larger vein to prevent extravasations into the tissues, just like the norepinephrine. And then the side effect of that is including increase of beta-1 causing the tachycardia, tachyarrhythmia, the palpitation. And then the dopamine. So the dopamine have a multiple use as dose-dependent type to from pure vasopressor to the inotropes, and also in other not shock status. It is helpful in those hemodynamic unstable AV block or bradycardia as well. Just after the atropine and the epinephrine. And precaution things is dopamine is the top inotrope and vasopressin of all that easily cause arrhythmia. It is an independent factors contributing to the atrial fibrillations. And in terms of the administrations, do not mix with the alkaline solutions such as the sodium bicarbonate, phenytoin, and the furosemide. And also to administer in large band is quite important here as well. So each institution should develop your own protocols to allow the largest, the highest level or the highest range of the acceptable concentrations in dosing in terms of whether in the peripheral vein or the CVC, and reduce dosage if either like urine output decrease or if there is increase in tachycardia or the development of new arrhythmias. Just stop the dopamine first and by taper down properly. And then let's go to the Dobutamine. Mainly have the inotrope as a first-line agent in the cardiogenic shock. And it has the cautions, again, cause the hypotension and tachyarrhythmias, and is incompatible with the alkaline solutions as well. And please monitor the signs of the myocardial ischemia, particularly in those patients with coronary artery disease. And as for the adverse event is quite important, as the pretty much mentioned above. So if we try to plot these pressors and inotropes by later inotropy effect with the vasoconstrictions effect or vasodilations. Here is the distributions, and with the upper first sections that you need to watch for the tachyphylaxis event. And as for the right lower bar, you need to watch for the rebound hypertensions, because these are just the pure inotropy with the vasodilations. Try to decrease the afterload as possible. And then another evidence providing you is we all as these pressors commonly with the alpha 1 or V1 or V1, V2 receptors that leading to the increase of the systematic venous vascular resistance, which pressors have the highest risk causing the mesenteric ischemia. So this is a real-world pharmacovigilance analysis by using the WHO's database, and you can see the agent that had the highest reporting odds ratio compared to the full database is the angiotensin, and then the Vasopressin. And the agent that has the least risk of the acute mesenteric ischemia is the epinephrine. So for the arrhythmias, here's just a few comparisons. There is a lot accumulated evidence around the risk of the dopamine. Here is just as a demonstrate to you that the dopamine compared to norepinephrine had a pretty high, actually more than 2 times risk of leading to the mortality outcome. But also for the other, like the atrial fibrillation risk. So it is reported as a more risky without providing a benefit in the mortality outcome. So just be cautious, do not choose dopamine as the primary agent, with the exceptions if the patient is purely bradycardia, right? And here is just the demonstration trial comparing Milrinone to Dobutamine, and you can see as the primary outcome or the other secondary outcomes, and also the safety as the arrhythmias event. These two medications is quite similar to each other with no significance detected in each outcomes provided. Okay, so let's move on to the acute life support and also other emergency cardiovascular care, and we've highlighted the 2 latest updated guidelines. One from the state is from the American Heart Association, and then the other is the guideline from the European Resuscitation Council. And also here, the AHA guideline has been endorsed and have the same recommendations by the EU Court guideline as well. So we're not going to go through every details in the ALS support, but rather with a focus on the pharmacotherapy related management. So first, the most important antiarrhythmias during this ALS process could be Amiodarone. So Amiodarone has acute indications not only in pulseless VT, VF, but also the stable with a wide complex tachycardia if the patient is stable. And then as the dose here, they have quite different in each other, but just remember mostly the first trial of Amiodarone could be up to the 2 ampules, which is 300 milligrams of the IV bolus in both pulseless VT, VF. And the second trial, if any recurrence or ineffective to the first dose, then just cut it to the half as one ampule of 150 milligram IV bolus. For the wide VT complex tachycardia, as the loading dose as the first one, it is different from different if different guidelines suggest either 150 or 300. That we are going to look at the algorithm together later. And after the patient had reporting of their spontaneous circulation from the resuscitations of the cardiac arrest, and then we need to keep on the maintenance dose of the Amiodarone as a continuous infusion drip by the first 6 hours with a rate of 1 milligram per minute, and followed by the rest of the 18 hour with a half rate of 0.5 milligram per minute. And the things to be noticed when reconstitute with the Amiodarone is to not, due to its solubility issue, it requires a non-DEHP or the PVC container. So it needs such as the PVC, a glass, or the PEP could work as well. And as importantly, to avoid any extravasations or the veins sensitive, the maximum concentrations for the peripheral vein infusion should be just keep at 2 milligrams per milliliter if the infusion time is longer than an hour. And the main effect of this is Amiodarone can lead to hypertension or the bradycardia, and as a long run lead to the dysfunctions in the thyroid. So have to monitor for those markers for T4 and T3 and also the TSH. And the second antiarrhythmic during the ALS process is lidocaine. It is indicated in the pulseless VT, VF, which is refractory to CPR, defibrillation, and also the epinephrine and Amiodarone sometimes. And the common dose as listed here, just for your reference. And then precaution thing is if the rounds with the lidocaine, which is dosing by the weight based, and then if infusions longer than 24 hours, try to cut a dose or taper the dose down to avoid the further toxicity is quite important. And what is the toxicity? It will lidocaine could have the other than sensitization or hypersensitivity. It might alter the consciousness and decrease the hearing, the paresthesia, or leading to any other bradycardia, and also the muscle twitchings, or even the local or generalized convulsions. But it's quite rarely to see, but just be cautious. This might be possible if it runs longer than 24 hours. And then we have the other agents of adenosine. Adenosine, which commonly have the packaged with the potency as a 6 milligram per vial. It is mainly indicated in the stable supraventricular tachycardia. So we often use it to diagnose or terminate the rhythm. By that saying means if the patient looks like presenting with a tachycardia but is refractory to the adenosine, then it means it may not be that reason as a stable, narrow complex. As the dosing here is important, we have the trial from 2 to 3 dose depending on different guidelines as well. So the first dose is the 6 milligram IV push, and then followed by the 20 milliliter saline as a flush, and then go with the larger dose as the second, as 12 milligram IV bolus, and then have the flush as well. And the third dose to give or not, if at this point it probably presents that clinically the patient is refractory or is adenosine is infective to that situation. But still, the European resuscitation guideline suggests we can try the third dose and increase it to the 18 milligram IV bolus, whereas the AHA guideline just stop it at the 12. And if you dosing the adenosine not terrifically, but administers injected with the central line, then we can all reduce the dose to the half, which is the 3 milligram as the first, 6 milligram as the second, and then 6 or 9 milligram as the third, to demonstrate similar clinical effect with the central line as the route. And things to precaution that must be injected to those men as proximal as possible to the trunk, and avoid the inject to the limbs, the hands, or the foot as a very could be very damaged to those vascular peripheral vascular. And adenosine cannot be used in those with a second or third degree AV block or has a sick sinus syndrome. And it also cannot be used with those has a wide complex tachycardia because it could be infective. And other adverse effect to that, including the transient flushing, headache, or the chest pressure, or sometimes cannot catch the breath. And so here is the algorithm when it turns to tachycardia of the age in the AHA guideline. So focus on whether the algorithm goes by if the patient has a persistent tachycardia and is not symptomatic. If it is, and probably will be life-threatening, then we need to immediately starting the synchronizing cardioversion. But if it's not that threatening, then we have the time to differentiate if that is a narrow or the wide QRS. If it is a wide QRS, then consider adenosine's role may be less possible, and only if those presents with a regular and monomorphic. And as for the adenosine dose as HA listed here, just for the reference, as we both talked about, and other than adenosine, for the antiarrhythmic infusion for the stable wide QRS tachycardia, that perkinamine can be considered, or the Amiodarone as the dose from recommend as the first, starting with the 150 milligram is a lower one. And this is the plot. It's the algorithms in the ERC guideline for tachyarrhythmia, and pretty similar for those unstable ones. Besides the synchronizing shock or the cardioversion, if unsuccessful, then Amiodarone can be considered as a pretty large dose as a 300 milligram. But also For those stable tachycardia with a wide QRS complex, then can consider if that is a regular rhythm. May use Amiodarone with a same as a higher dose compared to the AHA up to 300 milligrams. But if it is irregular in the wide QRS, then we need to think of to go as the atrial fibrillations algorithms for the management, and also to consider to give the magnesium or the isoprenaline as well as the temporary pacing to increase the heart rate, and try avoid amiodarone in that situation. And if a patient has a stable tachycardia and a narrow QRS interval, if that is regular, then consider first after if the patient is ineffective to this vagal maneuver, then the medication can consider is adenosine with the first as a 6, and then 12, and the third as 18 milligrams suggested here. So yeah, just the refreshing that adenosines have different suggested dose in between the HA and the ERC guidelines in the third doses from 12 milligrams over the 18 milligrams. And then here is the difference summary for the amiodarone in the whether ventricular tachycardia or the wide complex tachycardia. So the AHA is recommended with a more cautious step with the lower starting dose for amiodarone in this situation. Whereas the ERC guideline tries to hit the therapeutic blood levels faster with a double dose of AHA up to 300 milligrams of amiodarone as the first trial. All right, and let's go to the verapamil. So verapamil is also one of the common agents selected in the SVT, but after the adenosine or failed to the synchronizing cardioversions as alternative choice. And it also can be used in the idiopathic left ventricular tachycardia. The dose as the first initial from 5 to 10 milligram IV bolus over 2 minutes, and repeated dose can go to keep as the 10 milligram IV bolus again after a first quarter to third to half hour. And to keep in mind, verapamil should avoid use in those with severe hypertension or acute heart failure, and with a caution as well in those receiving beta blockers, because it might go as a synergy effect to the bradycardia. And verapamil is incompatible with a low fluid hyperalkaline, and its pH level is above 6, and it may cause precipitation. And as for the some side effects, including constipations, gingival hyperplasia if the long-term use, but it's less likely to happen. And also mainly is the bradycardia one, and sometimes hypertension. Okay, so the next one is atropine. Atropine has the acute indications in low hemodynamically unstable AV plaque or bradycardia, or in another poisoning as the antidote to the organophosphate or the carbamide poisoning. And here just to focus on the bradycardia and the AV block dose is quite easy to remember. It's 1 milligram IV push. Okay, the dose IV or the IM intramuscular, and repeated every 3 to 5 minutes. But after the first 3 attempts of use, that's it. The total maximum dose accumulated is 3 milligrams. And to be cautious, atropine has the rapid is needed to be administered rapidly as IV push. Because if we slowly drip it, slowly injections may cause a phenomenon called paradoxical bradycardia, and so have to also be used in caution with those have the ACS or the myocardial ischemia, because the atropine may increase the heart rate and thus increase the burden to the myocardial oxygenation demand. And if a patient has a cardiac transplant recipient, atropine will be ineffective to their bradycardia presentations because the stick to the IV node has been different after the post the transplantation. So side effects to atropine, including of course the tachycardia, and also as the antimuscarinic effect as a dry mouth, blurred visions, or sometimes urinary retention. And here is a comparison of the bradycardia algorithm from the ERC on the left to the AHA on the right. And actually they are quite similar, but with a slight difference of the atropine dose here. So the ERC, the ERC, when in terms of the bradycardia management, the first push dose differs. The ERC favors smaller, the gentler titrated, so starts at the lower as the 0.5 milligram IV atropine as IV push, whereas here in the IHA's perspective is in favor reaching a faster therapeutic level, so by merely started as the 1 milligram IV atropine. So for remember, half ampoule or a ampoule can be both considered in the according to these two guidelines. So lastly, let's talk about some other acute life support agent, but it's not a vasoactive agent. So first is the magnesium. Is composed with magnesium sulfate as the electrolyte, and it is indicated in both targeted points with 1 to 2 grams IV drip over 50 minutes, or if the targeted point is suspected for those highly differentiated VF or post-VD, then we can also try 2 grams IV bolus as well. And it also has the indicators as the eclampsia for the seizing in the pregnant women, or it is as a dose in the severe acute asthma exacerbations, which we talked about in the COPD and the asthma sections of our pharmacotherapy series. And some things proved to be precaution is the rapid injections of magnesium may cause hypertension, and we need to monitor the renal function as well. To adjust the dose if necessary. And the signs of overdose of magnesium includes both drops in the blood pressures and the heart rate, and also the those deep tendon reflex and or respiratory depression. As the next one is the 50% glucose. Of course, it's indicated in severe hypoglycemia and also the severe hyperkalemia, usually with the serum potassium level above 6.5, that we can dose as the from 20 to 50 gram, which is from the 2 to 5 vials needed, over each 5 minutes for the severe hyperkalemia. And precaution thing is the 50% glucose had very high hyperosmolar solution, so it needs to be slowly dripped in avoiding to any vascular damage. And the max peripheral administration concentrations is 50% only in an emergency setting. And the maximum concentrations of the routine use is a fourth of it, so which is 12.5% only. And then we have the calcium chloride or calcium glucose. So it is indicated in severe acute hyperkalemia, and also with during the cardiac arrest, only if the patient has been tested, have either presenting of electrolyte deficiency in hypocalcemia or hypermagnesium. And also it has the role in a calcium channel blocker overdose, of course, and to be cautious with the effect of it. And then precaution thing is including do not mix it with the sodium bicarbonate, because it would have the calcium carbonate precipitation. And also do not use in patients that had the digoxin or digitalis in toxicity, because it may both concomitant use may precipitate the life-threatening arrhythmias. And the calcium chloride or calcium glucose would have the side effects such as the feeling for the abdominal discomfort, bradycardia, or the hypertension. As for the sodium bicarbonate, which is commonly used to weather the severe acute and severe metabolic acidosis or cardiac arrest due to hyperkalemia, and it has explores with the doses from acute severe metabolic access can be used up to 9 amounts of ammo, as up to 100 milligrams, 100 equivalents in over IV push, and with repeated dose if needed. But it should not be routinely used during the CPR, only if it is indicated. And precaution thing is do not mix it with other medications. It's commonly incompatible with each other. And we should frequently monitor the pH value and also the serum bicarbonate to check with either the acidosis or the bicarbonate amount, and also to remember to monitor if that turns to the other side, which is the alkalosis as a side effect, if we're giving too much, or the hypernatremia as well, because it has the sodium contents in it, of the sodium bicarbonate, of course, and also precipitating to other electrolyte imbalance such as hypocalcemia, hypokalemia, and sometimes the abdominal distensions or bloating side effect can be present. All right, so thank you for listening. This is the summary of our sections of the vasoactive and other common acute life support medications in the ICU setting. So the first, as a quick review of the our inotropic and the vasopressin, choose to be based on different mechanisms, and also in terms of the fine and effective differential diagnosis to the types of the shock, so you can have the best choose, and also be cautious with the dose titrations and taper downs in sequence by its side to decrease the side effect. And the second part of our talk today, that we introduce this significant difference exists in the ACLS drug doses between the HA and the ERC guidelines in this year. and such as the Amiodarone, Adenosine, and Atropine. So to remember the difference and why. And then for other non-antiarrhythmic drugs that have a specific use and strict contraindications in the acute life support, such as the while epinephrine is the core drug for cardiac arrest, or like the calcium chloride, sodium bicarbonate have their primary role for metabolic emergencies as metabolic acidosis or hyperkalemia. And their administrations, however, requires pretty strict attention to the drug incompatibility and specific contraindications to the side effect as well. So thank you for your listening.